how prevalent is this issue of doctors making notes in patients' chart, unbeknownst to the patient many times, that could possibly jeopardize other healthcare providers from wanting to help them? This is a uh, so this is an emotional topic, right? So a referendum on whether chart notes that physicians make in a patient's chart could jeopardize future care for that patient. And I met with a young lady. Now, I was talking to her, and it was really heavy. It was really heavy. As she was referred, to other providers, they were in the same network. And in her chart were non-compliant patient, refused care, hostile patient. And she had gotten to the point, sorry, I she had gotten to the point that she said, "I don't want to live anymore." What she said was, "I want to make sure that these companies know that there are patients like me that, based on my experience with healthcare, the effect it has on patients."
Are you okay?
Yeah, yeah.
This is Genetics for Healthcare, a podcast for patients.
This is Genetics for Healthcare, podcast dedicated to patients and their caregivers to help advocate for a precision medicine approach to their healthcare, which includes disease screening, prevention, treatment, and survivorship. You can find us at geneticsforhealthcare.com. From there, you can connect with us on any of our social media channels, including LinkedIn. While you're there, hit that subscribe button so you can get updates and notifications on amazing new content like this one. I'm privileged to have Beatrice Preti, GI medical oncologist, who I became aware of after reading a paper that was published in the JCO Oncology Practice in July of this past year. And it was titled No versus No, NO versus KNOW, patient empowerment through shared decision making. And I also listened to an amazing podcast that she was on, JCO Cancer Stories, about the art of oncology. This is a conversation I've been waiting to get to. Dr. Preti, thank you so much for being a guest on Genetics for Healthcare.
Well, thank you so much for having me, bro.
So before we get into this, because this is like a hot button for me, give us a little bit of your background. What attracted you to a career in medicine, and why particularly oncology?
Yeah, so the origin story for both those is one and the same. When I was 8 years old, we had some, I guess they were cancer center nurses, I'm not really sure in retrospect, but come to our school and do a bit of outreach, kind of speaking about the work they do, about people or children with cancer. And at the end, they showed us this Charlie Brown video and kind of said, oh, wouldn't it be nice if one of you decided to grow up and help people with cancer? And me, all of 8 years old, was like, yes, sign me up. I'm going to do that. And I just never changed my mind. I explored different facets of medicine. Nothing really clicked as much as oncology. So that's my origin story.
I love that. My oldest daughter, Marlo, has, since she's been a little girl and got a Christmas gift of a anatomy book, has been so fascinated with the human body, and she knew that she was going to be a doctor. And she's a high school junior now, so she's headed that direction. But that story really resonates with me. So this paper really highlights not attention, but tension that arises when patients question or decline a doctor's treatment recommendation. And we're not talking about because they want to use herbs or, pray it away. We're talking about patients and family members asking questions, and they don't understand, or they don't feel that they got clarity from what their clinicians or healthcare providers have said to them. And so their concerns are not being addressed. And that leads to asking second opinions. And I've interviewed patient after patient, caregivers and families that mention that when this happens, the doctor really seems ticked off, that they become flip, that they become, I mean, you're dealing with a patient. These are patients who are battling disease. This
Mhm.
person is responsible for my care, and they just don't feel comfortable. And these doctors become agitated that they're asking questions or they're asking to speak to someone else who could possibly explain better to them. What do you believe is the root cause of this type of tension, especially with cancer care?
Well, I think it's twofold. I think on one hand, any conflict that occurs, even just in the course of daily life, often there's two sides, right? There's two perspectives. And in this sort of situation, definitely there are multiple things that can come into play. So, on one hand, every physician, every healthcare worker has an approach, they have a way of communication. Every patient, every family member has a way that they would prefer communication, that they would prefer the approach. Sometimes it's as simple as the approaches don't line up. So for me, I tend to try to stick to the approach of being quite forthcoming with information, to being quite honest about how I see things. I don't really sugarcoat things that much. Certainly try and convey information in a respectful, um, professional way, but to be quite forthcoming with the way I see things. Now, for most of the patients I would say I see, that works for them. And I'm upfront about this is my approach when we discuss things. I'm going to tell you the way I see it. Certainly, you're free to get second opinions. Certainly, you're free to ask as many questions as you like. There are, of course, a few patients that I will see, every year that perhaps that wasn't quite what they were looking for. And in those cases, certainly we encourage I believe every patient should have the chance to go out there and find a care team, to find physicians, etc., where the communication approach works for them, right? Sometimes it just boils down to communication styles. However, I think the other problem here is really rooted in how we train physicians right from the beginning. Because medicine, when you're being taught in a lecture, when you're taking a board exam, when you're taking a school exam, there's a correct answer by and large, right? And that correct answer is based on what treats the disease best. So, the best way of curing the disease, the best way of improving survival, decreasing morbidity from the disease. And in some schools have thought, that works. For example, if you're treating a urinary tract infection, someone's coming to you for care for urinary tract infection. I think the assumption is, and almost always correctly, that they would like the urinary tract infection gone. You give them the antibiotic, the infection goes away. But when we're dealing with something with cancer, it becomes a lot more nuanced because, especially in my line of work with GI medical oncology, we cannot always make it go away. And even for diseases that may be potentially curable, it is potentially. So it becomes a lot harder because there's still that board exam correct answer of, well, when we weigh the risks and benefits in the clinical trial or in the papers, this is the best answer, right? This is the one that in the study help people live the longest. But for many patients, their goal may not actually be to live as long as they possibly can. And also, equally importantly, for many patients, giving them what is often the most aggressive treatment available may also not help them to live the longest. So it becomes a bit of a conversation, a bit of a back and forth, because on one hand, you want to piece out, well, what are your goals to the patient? What are your goals? What are your priorities? What, what's important when we're looking down this road? And on the other hand, me as a physician, sometimes I have to be very blunt and I have to say, I know that you want to live as long as possible. But if we give you this most aggressive treatment, I'm worried that this may not be the case, right? I'm worried about the side effects, that they might be too much for you. It's a challenge because on one hand, the way that physicians are trained is here's the correct answer. And you have to deliberately think about and you have to deliberately train yourself to speak with people and focus more on values and kind of the shared decision making. And on the other hand, it can boil down to communication styles as well, communication preferences. Every two people on the face of the earth, you're not going to get along with everybody that you meet, right? And that's not right or wrong. It's just the way that we are. And sometimes the way that we speak or the way we interact may not work for everybody that we come across.
Great explanation, by the way. And at the top of this, I announced the name of your paper and I didn't complete it. It is No versus No: Patient Empowerment Through Shared Decision Making. And on that topic of shared decision making, you just mentioned it. like many people are shell shocked with the news of a cancer diagnosis
Mm.
or of any chronic disease condition and their prognosis, right, which is the forecast outcome of the situation by their providers. I can imagine it's very hard for someone who's just gotten this news to process and make any type of decision,
Mm.
even with time. And when you throw in the challenges around communications that you just are just beautifully laid out. I mean, that's a problem anyway. Like just in marriages and friendships and in business. But what does shared decision making for patients, particularly for cancer patients, what does it look like with
Mhm.
the growth of precision medicine providing more options than ever before for cancer care? What does that actually look like in the clinic?
So there are different ways to describe shared decision making. The the model that I tend to use or I tend to think of is that it's a conversation. So it's a conversation where I, as the physician, typically have the knowledge, have the studies, have the guidelines, have all of the tools that we could use in my pocket. And when I go in and I meet a patient, I will be keeping all these options in my mind. When I open my consults, usually I will say, "Tell me about yourself. Tell me about what matters to you. Tell me about your loved ones. Tell me, do you work? Do you have hobbies?" In a way to paint and gain an understanding of who this person is. Somebody who is very frail, or somebody who has specific hobbies, or somebody who loves to work, or somebody who maybe has lost a spouse to cancer and is apprehensive about the treatments ahead and the options ahead. In my head, I'm usually weighing all the things that the patient is telling me. Now, for a lot of the cancers we see in the GI world, if we look at every possible way we could treat this, probably maybe 4 to 5 options at most. Often it's more like two or three. And I will present these to the patient and I'll say, here's the cancer, here's the situation. We can cure this, we can't cure this, but we can treat it. And here are some of the options. Here are what things look like. It might be as simple as, we have an IV and we have a pill. It might be more, you mentioned precision medicine. If there are targets that can be targeted, we'll mention those, we'll bring those up. We mentioned as well earlier on about like herbal supplements, etc. For some patients who either express an interest in that, or some patients where maybe the medical options are not the most desirable or leading to the best benefits, sometimes I will mention those as well as things that people choose to consider when they're weighing all their options. And then again, just having a conversation with every person that you meet, it's going to be very individualized, it's going to be very different. But really taking the time to try and piece out what's most important to them. Now, I agree with you, often these conversations are overwhelming, they're quite daunting. So I try not to push anyone to make a decision unless time is of the essence in the clinic. And if possible, to take overnight, take the weekend, take a week to think about things, ask any other questions that might come up before deciding what it is they want to do.
I think that speaks first of all to the bedside manner, the skill in which you have, the compassion in which you had, because the first thing you said to facilitate shared decision making is that you take time to understand the patient, not just understand what the patient wants, but understand them, their lifestyle. I recently spoke to Matthew Zachary, who is a patient advocate, and when he was around 20 years old, he was a concert pianist and he was headed to Los Angeles to grow his career, derailed by the diagnosis of a brain tumor, and he was offered chemo because that's what you did to treat brain tumors. And thankfully, through his father and a physician friend of the family, they decided against chemo, which was, like, what do you mean? Don't you want to be cured? But here's what was important to him. The neuropathy and the potential risk of the treatment would ruin his ability to play piano. And for him at 20 years old, he said, I'd rather play the piano the rest of my life, however long or short that is, versus not doing that and living forever not being able to do the thing that I love. And fortunately for him, today he still is able to play the piano and he's alive, 20 plus years after that decision to not take chemo. But getting to know that patient, helping them understand what was right for them, that's a credit to you as a clinician because many patients don't know the questions to ask. They don't know that they should ask questions. Many patients have said they don't know that they could ask a question because I'm just here for you to help get me well, right? And whatever you say, I guess I have to do. Do you see this shared decision making approach evolving in oncology with the explosion of precision medicine? And do oncologists need training to have these conversations?
Yeah, so two great questions. I mean, precision medicine is one thing, but even in general, the treatment options in oncology are rapidly expanding. GI oncology is one thing, but in other disciplines like or disease sites like breast, like lung, etc., um, for one particular kind of cancer, there are many, many potential treatment options. And again, some of them might be seen more favorably by the medical community. Some of them have better survival advantages. Some of them have better side effect to um, survival or side effect to outcome ratios. But kind of as you just said in this example that you gave, you really, really have to look at the patient. Now, I'm lucky in a couple fronts. One is that during my training, I had the opportunity to work in a center and work with an expert in shared decision making who really coached and trained me in this approach of don't just focus on the textbook answer, focus on the patient, and the patient will tell you what the best option for them is. That's certainly not something that is trained in oncology. I think it's important, and I think that we need to. But it's also challenging, right? Because on the flip side, you also want to train competent physicians. You want physicians who know the data, who know the literature. And in some cultures, in some schools of thought, the best option for the patient is the one that has the potential to help them live longer. So there is also a cultural component to this as well. But I think it's something that, kind of like we're doing here, that we just need to speak about more and more. Because on one hand, as we empower patients, encourage them to ask questions, encourage them to take their health into their own hands, right? And understand that they have power and they have the power to make decisions that work for them. But also training physicians and training young physicians and learners and medical students and residents and fellows in there's a battle that's described between two moral values, one beneficence, so wanting to do what's best for the patient, and patient autonomy, where the patient has the choice to choose what's best for them. And even in early medical school, even before medical school, there's a teaching that these are often in tension. And as a good physician, you have to defer to patient autonomy. So patients always have the choice to decline your recommendation, to choose their own path, etc. But I think with shared decision making, it's less about seeing a tension between these two, beneficence and autonomy, but how do we make them work together, right? Because sometimes allowing the patient to choose for them is what's best for the patient. It's just so different from the way that medical school curricula are crafted, board exams are crafted, right? There's never on a board exam, or rarely, not on any board exam I took, that they have a question where they say, oh, the patient wants this, they're worried about side effects, what would you do? It's, here's the data, what's the best option for this patient without thought about, what does the patient want?
Your paper opens with you sharing a narrative about a clinic day that you had. And that particular day, you report that you saw three patients back to back who were there for a second opinion, and all from minority backgrounds. And you mentioned that in looking at the chart notes, there were notes from previous providers that said they refused chemo or whatever the course of treatment is, or they refused hospice. And you make the point that the patient didn't necessarily refuse, they declined. And they may have declined because they did not understand or wanted more information about what other options could be, or further information about the risk versus benefit of the proposed care. This is an emotional topic, right? So it is what's the word I'm looking for? It is a referendum on whether chart notes that physicians make in a patient's chart could jeopardize future care for that patient. And here's where I'm going with this, Dr. Preddy. I recently covered Health USA, which is, it's a healthcare conference in Las Vegas, huge healthcare innovation conference. There was no clinical data there. It's really all about the investors and what's the future of healthcare. AI was on everything. I mean, it's just overwhelming, like 12,000 people. But the most impactful experience that I had is they had a patient area there, and and it says, ask the patient. Eureka. So I went in and had these conversations, and I met with a young lady that, I mean, she had multiple, conditions, multiple illnesses, neurological. I think, one of the most really bothersome for her, problematic, was like lupus or something of that nature, where it was really chronic pain that went along with some of the neurological, the psychological, the physical things that she had. And I tell you, and I was talking to her, and it was really heavy. It was really heavy. And at one point, I had to ask. I said, "Well, what is it that like you would go and seek treatment for?" And she said, "Honestly, I don't know." But the point she made is that as she was referred, to other providers, they were in the same network, and in her chart were non-compliant patient, refused care, hostile patient. I She had gotten to the point that she said, "I don't want to live anymore." And when I was sitting there talking to her, I mean, it was so heavy. And I said, "Well, why are you here? Like, what do you want to happen as a result of having conversations?" Because at that point, I had no idea what to do, right, and or how to talk to her. And what she said was, "I want to make sure that these companies know that there are patients like me that, based on my experience with healthcare, the effect it has on patients."
Mhm.
And I guess I'll never forget that experience. And I have to ask you, how prevalent is this issue of doctors making notes in patients' chart, unbeknownst to the patient many times,
Mhm.
that could possibly jeopardize other healthcare providers from wanting to help them?
Yeah. So that's an interesting question. And it's quite quite a loaded topic. I'm doing my PhD right now, and one of my PhD cohort is actually doing his whole PhD around this topic about patients accessing the notes, what's written in the record, etc. Are you okay?
Yeah, yeah.
Yeah,
It's just
it's tough.
it's tough, and I guess I was so taken by her courage
Yeah,
to be at a conference like this, and she wasn't saying this for any pity or sympathy.
yeah,
She was there to inform the healthcare community that, like, listen, people matter.
yeah,
And when patients push back on you, it's because they feel that you don't understand them, and they just really want help.
yeah,
And they may be frustrated, they may be, upset, because it's their life.
yeah,
And I don't know. I'll just never forget that. And this is
yeah,
why your paper is so important, and this
yeah.
conversation is so important.
And I think this is hard because going back to what I said too about the perspective and the perspective mismatch, the notes is actually something I struggle with quite a bit because I think on one hand, when you read another physician's notes or you're reading a patient's record, you have to have a bit of an open mind, or you have to have an open mind, period. Because you need to review everything that's documented, you need to review the patient's course to date, etc. But you also have to be willing and able to walk into the room and start with a clean slate with that patient that's across from you. Now, I know right now, especially in the United States, most patients will have access to most, if not all, of their record, of their notes, etc. For me, this is something that worries me a little bit, though, I'll have to admit. Because for me, the notes I write are, first of all, for me as a reminder. They are for other healthcare team members who might be caring for the patient, and they're also for potentially a lawyer, judicial system, a judge who might be reviewing the case, for example, in malpractice. Unfortunately, in the line of work I do, we do see or we do have interactions with patients and family members that are dangerous for us as healthcare workers. I've been punched by patients, I've had
Mm.
care team members bitten by patients, we've had patients bring weapons into clinic, threaten us, etc. We also have patients who do share with us prejudiced comments directed at us as healthcare team members. Now, for me, this goes in the chart. And even if it may not go in the patient note, it needs to go somewhere. First of all, for the protection of my team and myself, that we have this documented, we have this written down, and that we know, moving forward, that perhaps this is somebody that two people need to go in the room with instead of one. Of course, I understand, and I've heard from patients that this can be damaging for them, but it's challenging, right? It's challenging. Now, of course, this is one extreme, and most patients do not get to the point where they're biting people. Um, but on the flip side, kind of as you opened up with simple terminology, for me, patients do not refuse treatment. Right? Patients decline a treatment recommendation or they make a choice. Because it's not as though we're forcing things on people, right? And it turns into the wording of things. I might say that, security was called because the patient who was biting people refused to leave the premises, but this is a bit of a different situation, and I would hope that any listener listening would kind of understand the difference there. Um, but it is something to consider. And certainly when I write my notes, I'm cautious about what I write. I'm cautious about how I say it. Um, on the flip side too, when we're writing notes, or you're doing any kind of medical documentation, sometimes you're wording things medically as well, right? And the way I would explain things to patient may be different than what I would write in the notes. Um, might be different from how I would communicate with another healthcare provider, another physician as well. I'm not sure that the solution is necessarily to change the documentation. Certainly watching the wording, yes, but the contents of what we're writing down, I think, are important, especially remembering that it's kind of a blanket rule for everybody. I think what's more important though is when you're a doctor reading the notes to keep an open mind, right? I will not decline to see a patient because there's a documentation about violence or prejudice comments, etc. But perhaps it will just mean that I will take someone in the room with me, just in case, right? Or I will ask our nurses, hey, can someone be in the clinic space just in case things get a little out of hand here? But still going in with an open mind, listening to that patient, listening to their side of the story, listening to their side of things, and trying to do the best that we can in the moment to help them.
I appreciate that perspective. So let's talk about presenting options for patients. To take you a little bit inside of, my personal story, my father is a 20 plus year colorectal cancer survivor. And when we were sitting there with the oncologist for that first consult, the language that was used is, what we have to offer you is 5-FU, foreign, combination of two, cytotoxic therapies plus radiation. What she did not say is that at that time there were no other options. That it was it, right? So and I don't know how many patients are in that situation. Again, they are there to be healed. The doctor is the expert. You are my angel of my saving grace, and what they say is, here's what we have to offer you. Now, here's the deal: for different tumor types, there are different options. And if we look at lung cancer has come quite a long way with the offerings, the targeted therapies that are available. But there are still cancer types based on your stage and grade, that there are different options. There may be a standard of care, but there's still different options, and the response rates and the outcomes may not be that different from the standard of care, but maybe because of side effects or cost or whatever, that is the standard of care. Now, here's the deal: we know that every doctor cannot go over every option and what the data says and all that, for the lack of time and just for the sheer overwhelm, for that patient. But when you consider the time constraints that you have that are upon you when you go into a clinic, how do you handle the offering of what you or the data says may be best versus letting that patient and their family know that they have options.
I think that boils down to what we are speaking about earlier and how it's so important to take the often less than 5 minutes to get to know the person sitting across from you, at least as best as you can in less than 5 minutes. What's important to them, right? What are their goals? What are their values? What do they do in their day to day life? How is their physical health otherwise? Do they have other medical conditions? What's their history with medications, with healthcare team, with cancer? What are their experiences? You would be surprised how easy it is to start narrowing down options based on what people say and also based on the parameters of their cancer. You mentioned colon cancer. Unfortunately, these days we don't have a whole lot more options than the ones that you're describing 20 years ago, especially for curative intent colon cancer. Often, what it will boil down to is me writing on a piece of paper, here are the 3 or 4 options that we have for your cancer at this point in the game. Now, maybe this one I think might be too strong, or this one isn't in line with your goals, but let's talk about the other couple and let's see, what do you think? Let's have a conversation.
Yeah, I think explaining options just opens up the possibility for that family and that person to choose an option, that you could possibly disagree with, but that might be best for that patient, right? And you even mentioned in your paper that sometimes they choose other options that you don't agree with because you may feel they're healthy enough to get a more intense therapy, but they choose a gentler option. Some cases where chemo is recommended, they decline because in the instance of Matthew Zachary, something they're less willing to risk something that may interfere with, right, and
Mhm.
even hospice. Right? So some people, don't know what really hospice is.
And I think too, this boils down to this is why it's important for me at least to be frank and upfront with people. Because once you start putting the cards on the table and you start explaining, if this is or is not curable, and here's the chances of this being cured, and here's how much benefit the treatments we're talking about can give you. Sometimes you will be surprised about the choices that people make. Sometimes you may not be surprised if you get to know them a bit. But I'm a huge fan that, especially in the landscape where I work, where a lot of cancers are not going to be cured ultimately, where a lot of people in oncology, we talk about the 5 year mark as being like the cure, the survival gold standard. A lot of people are not going to make that 5 year mark. How are we optimizing the choices that can be made, and how are we optimizing the patient's life, I guess, right? In a way that's most in line with their wishes. Because I think that in the ideal world, everybody who has cancer, they'd love to take a pill and have it gone. But that's just not the reality of what we're working in. So, what can we do with the information, the resources we have to have the best outcome in quotation marks for the patient?
I can't say enough about how you wrote the paper. It showed, introspection and vulnerability from a clinician. You are a gastrointestinal oncologist that works at academic institutions. You are writing papers, you're doing research, and you're training the next generation of clinicians that are coming into the workforce. So there's so much that I like about the paper. When the first time that I uh, wrote it, the first time that I read it, and I just want to read this excerpt because I think it's just worthy, right? Um, you write in the paper that I will admit that, like many, I do struggle at times when a patient does not select the medically best treatment for themselves. But why? Do we fear legal repercussions or complaints down the road from not giving a patient the standard of care? Do we struggle with the moral distress when a patient makes a choice that we disagree with? Do we lack time in the clinic to walk patients through different options? Picking the method of counseling that allows the most efficiency in a packed clinical system? Or is it too painful a reminder of our morality to consider that, especially in the setting of terminally ill patients, aiming for anything other than a shot at the longest length of life might be a patient's preference? Or are we so burnt out from working in a system that denied us sufficient choice and autonomy with regards to our work, our own morals, and our own lives, that under such repeat traumas, we lose touch with the idea of even having a choice? I got to ask you, what were you experiencing on this day when you wrote this? Because it sounds so cathartic and deep.
Well, I'll tell you that I wrote this the evening of, like, as the paper says, the evening of that particular clinic. It's something that's a bit tricky in medicine, especially as one becomes a bit more senior, because sometimes it's difficult to write openly about the things that we're seeing and we're witnessing. And sometimes, kind of as I said in this paper in the excerpt that you read, sometimes there's questions that you're posing, but there's no clear answers. And I think when I was writing this, was feeling kind of a little of all of the above, right? Um, and that's something too that's challenging because again, medicine with its medical school, medical training with its emphasis on how you treat, how you cure disease, doesn't necessarily train you for how to tackle fears of your own mortality, right? Or how to tackle, yeah, any of those really.
Well, it's my hope that as precision medicine grows and genetic and genomic information provides more options, not just in cancer care, but across many different diseases and conditions, that more doctors have this level of compassion and introspection with considering options and getting to know patients and encouraging informed shared decision making on both parts. So, Dr. Preddy will get you out of here on this. I always ask my guests, whether it's a patient advocate or a scientist and expert, for three practical tips. And in this case, I'll ask you two different things. So, what are three practical tips that patients that you would give patients to help them build confidence to advocate for themselves in making shared decisions? And also, three tips that you would offer your colleagues to help foster the atmosphere of shared decision making with their patients?
So there's some overlap. From the patient side, I think number one, don't be afraid to ask questions, right? Ask your questions. Um, and also take time to think about the questions you have, write them down, bring them to your clinic visits. There should always be room and communication and the ability to ask questions. If not, it might be a sign that maybe the communication styles are not matching up. But ask your questions, think about your questions, think deliberately about what's going on, what matters to you. And the third one is that I'm a big fan, and this is going to sound strange, but I'm a big fan of seeing the humanity of others. And for the colleague side, and for the patient side too, I think a lot of the struggles in medicine is that we see people in their role. Going to some of the struggles of being an oncologist and some of the moral distress and some of the distress in the face of the suffering that we witness, it can be an easy trap to fall into to see patients in their role rather than, here's a woman who enjoys gardening, who, has three children and happens to have lung cancer. You see a woman with lung cancer, it might be a little much to ask or expect from people who have been diagnosed with cancer, but by the same token, right, your physician, your healthcare team, they are people. And if you can connect on that human level, there's some patients that I can connect with because we have a love of gardening, right? Or we have a love of music. And every time that they come into the clinic, let's spend a few moments just speaking about your garden, speaking about music, speaking about what new songs you're listening to, right? It lends a very different perspective to the conversation in general. And then from the physician side as well, taking the time to speak to your patients, right? Can be done in less than 5 minutes, but really, who is this person as a person, not as a cancer, right? Not as a scan or as a pathology, but who is this as a person? What matters to them? What's important to them? Because I think a lot of the struggles that we have and a lot of the difficulties that we have in medicine can really be boiled down to a lack of communication or a need for more communication, than a lack of seeing each other as human and connecting on that human level.
Well, I applaud you. I always say I need an applaud track in my podcast because if I've had one, I'd push it right now. I thank you for your work. I hope to see you at future meetings talking about this particular topic and using your experience in your paper as a backdrop. As I know, many of your colleagues, they want to do the best they possibly can for their patients, and taking this type of approach to empower patients with shared decision making can certainly help us all get better at what we do. Dr. Beatrice Preddy, gastrointestinal medical oncologist and author of the paper, No versus No, Empowering Patients, Patient Empowerment Through Shared Decision Making. Thank you for being a guest on Genetics for Healthcare.
Thank you so much for having me.
This is Genetics for Healthcare, a podcast for patients.